Chris, we on?
We're on. Yep. We're on, Will.
Hi guys, how are you? Welcome to Chattanooga, Tennessee. Thanks to BD for sponsoring this and Emmertech for helping us out with everything. Tate is here in the room. He's helping us out with the audio visuals and broadcasting us live into the Marriott. And I've got a great team here today. I've got Krista manning the computer as our nurse. And then Sophia's right here next to me, and Aaron and Holly over there, and Christine providing anesthesia. So we've got a great team here and hope to bring you a good case. While we were waiting with a little bit of a delay, I went ahead and got access. But we have a really pleasant 48-year-old female. I think Tate has the slide deck up, who has pretty significant swelling, cramping, fatigue, and pain. She's very active, was walking up to 5 miles a day, recently moved here from California. She is a Navy veteran, and she's become so disabled with the swelling, the achiness, the cramping, and the pain that it inhibits her from walking much more than a mile every single day. And she has fatigue and swelling that's pretty horrible towards the end of the day. We've done a venous reflex ultrasound on her as part of our standard workup, and I believe that was just recently discussed in your ultrasound session today. So, Kate, can you? I'm not sure where we are in which slide it is. Okay, that slide is up right now, and you can see that her venous reflex ultrasound was pretty underwhelming for the kind of symptoms that you would expect with her. So she did have some fairly larger greater saphenous veins proximally, but very little reflux, and wouldn't really characterize it as what I would expect for her symptomology. So moving forward, we did measurements of her inferior vena cava and her iliac system, and that was significantly more impressive. She had significant iliac compression. And so we counseled her and talked to her about the merits of intervention versus conservative measurements, non-operative interventions, and she elected to proceed and wanted to go ahead and have us do a venogram and take a look up top. So feel free to stop me with any questions. We got access in the common femoral veins bilaterally. We have two 10 French sheaths here. And you can see our ultrasound on the left, and the ultrasound is the artery, and the right is the common femoral vein. All of our access is ultrasound guided. Sometimes I will stick the greater saphenous vein for some of these accesses. You can see the saphenous vein coming in here, but I've got the sheath going into the common femoral vein on the left side. Again, we've got two 10 French sheaths in, and we've done, and we have two Benson wires, and we're going to do bilateral venograms right now. Kind of take a look and see what you see.
Good morning, Dr. Harris. I just wanted to let everybody who is observing know that you are able to move the overlays around, and then at the bottom right-hand corner is a blue box that will allow you to resize them so that you can enlarge the fluoro screens, the IVUS image, and anything else that may be pertinent during the procedure.
Yep. Thank you, Robert. All right, digital subtraction angiography. See how coordinated I am to run this. Okay, you can see the veins running up, and it appears that it looks, a venogram is a 2D representation of a 3D view, but it looks on the right side, the right kind of distal common iliac vein is fairly small, is a little bit smaller, and then you see a very widened out left common iliac vein, and you can actually see, Aaron, or Ollie, can you draw the collateral that you can see coming off shooting north? Can you point that out with an arrow? And you can faintly see that collateral shooting north, and that's something that you can sometimes see with significant iliac venous compression, is the formation of collaterals taking up flow to return blood flow back up to the heart with iliac vein compression. But it looks like the vein's wide open in a situation like this, but stay tuned. We'll prove that it is not. All right, so now we're going to go in with our intravascular ultrasound. Intravascular ultrasound is really gold standard for diagnosing and management of deep venous disease. I think that doing venograms and interventions without using IVUS is a criminal act. That should be done. Yes. Yes.
This is Chris. Do you have the IVUS slaved to the monitors?
Yes.
So we're not seeing IVUS, which would be really, I'm sure all the ultrasound techs would love to see that. And maybe we're getting that organized.
All right, I think we got
There
a
it
heartbeat.
is. Oh, there it is. Thank you, sir.
Congratulations, I'm not pregnant. That's one thing. So, all right, we've got the IVUS catheter inside the vein right now. This is on the right side. Spot, Holly, please. So we're going up on the right side. Be a little more slack, would you?
Where are you
See
at?
a little bit narrowed right here, Spot. And we're up very proximal, so the vein gets pretty significantly narrowed. You can see a fair amount of pulsatility coming from it. That's from compression from the surrounding artery. You're probably near the aorta and the right common iliac right there. You can see the wire on the other side coming in. And the inferior vena cava itself is somewhat compressed as well. If we took this probe way up, you can see the inferior vena cava kind of widens out and becomes significantly more open.
It
So
looks
we'll do a pullback record.
It looks a little underperfused. That vena cava looks to be pretty small.
It is very underperfused. And it could be because she's dry, but I think she also has pretty substantial disease. So we're going to come back right here. I could actually feel like give in the ultrasound probe as it came by this one segment, and then here, the external iliac, it gets pretty small for the size of the lady she is, and then it widens out and kind of opens up again. And you see how much wider it is down here in the distal external iliac as opposed in the common iliac. And that's not natural. Stop.
Will, what does the femoral vein look like at that level? I'm just curious to see the diameter on IVUS.
Well, I stuck to the common femoral vein, but it looked fairly wide open on ultrasound when I accessed it. So we'll go in now and run into the left side. So we're going up with ultrasound up into the inferior vena cava again. And I don't know if you can track both our x-ray, but look, I'm getting a fair amount of resistance, and then boom. As you can see, there's fairly significant compression. So let me rotate the IVUS so you have more of an anatomical view. As you can see, the iliac vein, that's what the catheter is in, and it's almost occlusive. Sitting right on top of the iliac vein is the right common iliac artery.
And so the artery at the top, the spine below, and the vein in the middle.
Correct. It's a pancake. And then it opens up and we're back in the inferior vena cava. So kind of a classic picture. Record.
Were her symptoms mostly left-sided or bilateral?
Bilateral, interestingly enough, somewhat worse on the right. Slightly worse on the right, but significantly bilateral fatigue, bilateral pain, cramping, swelling. Stop recording. So, live on IVUS. What I do in a situation like this, especially since I think she has concomitant right-sided disease. Left-sided disease is much more prominent. There's right-sided disease as well. Spot. So I mark kind of a normal point of the inferior vena cava. Thank you. So we're just going to make a mark there, and that's going to be a kind of a general landing zone. I'll go up and confirm that, putting in my IVUS up the right side to make sure I agree with that. I got a couple 16-1, probably 16-160 for the right and 16-140 for the left. Or 16 for the right and a 16-120 for the left.
So you're picking stent sized based off of.
Yes, sir.
based off of
I'll
what?
go pretty long on her on the right side spot, just because I really want to get down into that external iliac, because I think that's pretty significant disease in narrow 2 spot. And so I think that's a good place to potentially land my stents right here. These markers that you can see on fluoroscopy are 1 centimeter markers. So a 16-160 should get us to where we need to go. Record. And I like my marker placement. Perfect. Okay, stop recording. All right, so we'll put up both stents at once. Beautiful. We're using BD Venovo stents in this instance. We're using a 16-160 on the right-hand side and a 16-120 on the left-hand side. And for an average-sized female, these are kind of standard diameters that I'll use for the venous system. I definitely don't want to undersize the stent. That could have somewhat dire consequences. Which side is it? Perfect.
So the typical range of stent size for most patients is somewhere between 14 millimeter diameter to 18 millimeter diameter. A man with large veins, you might get 18 to 20, but that's generally like the upper side. I would say most patients, at least in my experience, about 80 to 90% somewhere have about a 16 millimeter common iliac vein, and it will accept that level of stent.
And BD has sizes all the way up to 20 and stents as short as 40 and all the way up to 160 in length. Perfect. Fine. Can I get a couple of 1480 balloons, please? And so I'll put the 2 stents up and I'll put them up kind of parallel next to each other. This is how I standardly deploy 2 stents at once. I'm not coordinated enough to deploy both of them at the same time and think that I'm going to do well. And so, live on X-ray. So I'll start off with one a little bit higher than the other, and then I'm going to start off on the right side, just a little bit of a straighter shot. I'm going to start a little bit higher than my mark, fine with me, and work my stent all the way down. The Venovo has a triaxial delivery system, so I can deliver it very precisely. With these. Holly, can you move south just a skosh? Skosh is a medical term that we use with routine. Live. And that stent's released very nicely, so Sophia's going to walk it off for me. Okay, can you go back up a little bit, Holly, and give me a magnification on that? Here, I can move.
So one of the objectives while he's finishing the second deployment is to cover, to expand, place a stent that will open up all areas of compression. We don't want to leave any compression behind, no compression behind. And we also use a longer stent because we technically don't want that stent to move. That stent will stay in place the longer it is versus if we use a real short segment.
Yeah, I really want to make sure that I land it into healthy vein, correct? Non-compressed vein. And so what I do here is I'm putting up a balloon and I'm having this serve as kind of a buffer. So it's into the inferior vena cava, and this is a 14 millimeter balloon. Now that I've done this, I can make sure that my other stent that I'm about to deploy doesn't collapse the stent that I already have open. So I'm bringing this stent down. Now the BD Venovos have kind of a flared proximal portion to it, which we've learned to use to our advantage in these situations. So that's perfect. The balloon's doing exactly what I want it to do. And keeping that part open. We land them pretty close to each other at the top, so there's no real overlap. Come off your zoom, please. And I like that right there. And so we're going to walk that off and go in with a second balloon. Now, I often get the question from patients, can we just balloon it, would that be adequate? And in a situation with non-thrombotic venous obstruction, a balloon doesn't cut it, because you'll instantly collapse. There's no real benefit to only ballooning. There's not enough radial force. It doesn't have any long-term effect to the vein. As a matter of fact, it probably damages the vein more than it helps the situation. So these stents are nitinol based. You know, they have a fair amount of radial force. They have a significant amount of radial force, and they're indicated for use and approved by the FDA for this exact purpose, placing it in the iliacaval venous system. Or correction, I'm sorry, the iliofemoral venous system.
So that is.
So we've got two balloons going up here, and we'll just bring them down at the same time. 1, 2, 3. Sorry, Chris, I cut you off. What'd you say?
No, I think it's a good distinction. You know, the technology was designed and built for iliofemoral stenting, but what we find is that you have to place this beyond the level of obstruction, or you still have obstruction, and oftentimes it's at the distal vena cava. So I think that you know, industry and regulators need to catch up to really where we need to be to actually treat this condition.
I'm pretty happy with the way that both of those stents deployed. Now we'll take the completion venogram. All right, DSN. And as you can see, the flow through there is brisk. And I'm pretty happy with that.
Looks
that
like
collateral that you see on the right side will probably go away pretty soon, now that we've relieved the obstruction.
yeah, vena
Or it'll
cava.
completely collapse. It may not go away, but it'll almost completely collapse. We have the intravascular ultrasound in the right side, and as you can see, this inferior vena cava is a whole lot bigger now that we've put the stents in. Record.
So that's one of the common questions I ask patients when they have evidence of venous obstruction like this is, do you have difficulty walking? Do they get short of breath? And it's a fairly common thing that we'll find, especially.
They're actually starting to see some more relation to POTS, postural orthostatic hypotension related to venous obstructive disease. I think you're going to start to see more data come out as far as that. Now we've got the IVUS up the left side. And you see the stent coming through right there. I went through a strut. Sorry.
Yeah. Yep.
I'm still going through a strut.
Looks good, Will, though. I mean, it's still widely open.
It does.
What was it? What was the percent stenosis calculated in that?
On the left side, it was 90%. On the right side, it was about 60. Record. And we look at healthy vein diameter and compare it to unhealthy vein diameter, right? And so that's how we do our diameter calculation. Stop recording. That's pretty fantastic right there. I'm pretty happy.
That's awesome.
So what my protocol is we'll typically keep her on either systemic anticoagulation, or I do a lot of times dual antiplatelet for the NIVL patients for approximately 6 months, and then I recommend a baby aspirin for the rest of their life. You know, there's no clear guidelines as far as these go. If the patient is post-thrombotic, then we'll keep them on, you know, a systemic anticoagulation for a fair amount of time, you know, but I know people who do these and only keep them on a baby aspirin, and they seem to be fine too. So, and I know people who do full systemic anticoagulation for a year. So I don't think there's a right answer as far as this goes, or a wrong answer. We're trying to experiment for pain control in these patients. We're sending them home on Robaxin, muscle relaxant. This was Krista's idea, and after pulling some patients, it's been a really great idea and a great way of treating these. The patients will have some musculoskeletal pain, flank pain after putting these, because it irritates the nerves on the psoas and things like that. So, but really, I think really solid result. I'm very pleased. Any questions, Chris?
Yeah, I'm just, the audience is grabbing some lunch. Is there any actually questions about the technique so far or any issues? Looks like they're enthralled with lunch and the video. So I think we're going to step away from here at this point. So at this point, the successful operation, pretty happy with it?
Very, very.
And I think that took you all of 20 minutes to do it?
Yeah.
So I think
Enough time to go get lunch.
So there's a lot of thought process that goes behind deciding who is a candidate for this type of procedure. It's proved by intravascular ultrasound as to diameter reduction. Generally, Will, one quick question. What's like the minimum diameter reduction that you would treat in a patient like this with symptoms as severe as she's had?
60% is the gold standard in the United States. Kind of. That's what the data is based off of and everything else. So typically we shoot for diameter reduction around 60%.
Fair enough. Okay, so the question was, how are you going to close?
How am I going to close? So there are a lot of expensive ways to close, but I'm just going to pull the sheets out and put a little suture in it. And it works great.
Yep.
Little figure of 8. Remember, it's venous, so it's a low pressure system. So, you know, for 10 French sheets, it works well.
Yep, and we often just support that with a little pressure dressing. No, we tape it on, and we leave it on for 24 hours. Sutures is a dissolving suture, so after 2 weeks it dissolves and comes out. So they just shower right over top of that.
Correct, it usually just falls out on its own.
Yeah. I'd say most people have, I always tell most of my patients, at least 3 days of pain in that low back, low pelvis. It can be longer. I've seen it 6 days. I've seen it a couple patients with severe obstruction up to a month. But most of the time it's tolerated fairly well, and people can start to feel better fairly quickly.
And I think I used to see more flank pain and things like that persisted long terms, where we were using different types of stents that weren't necessarily indicated for this sort of thing, and using the wrong size of stents on these patients. And so I think with the advent of the newer technology stents like the Novo and appropriate sizing, I don't see as much pain-related issues long term as we used to.
Will, thank you very much. We appreciate all your efforts, and thank your patient for us.
Hey guys, enjoy the conference, and I'll see you all tomorrow.
All right, excellent. Thank you so much. Signing off.
Cheers. Thanks, Robert and BD.